kidney transplant program at Children's Hospital of Michigan. He has also received many awards. He has received the Best Teacher Award of the Year from Michigan Children's Hospital, and he's also been nominated for Excellence in Teaching, and he has also received the Top Nephrologist Award by Detroit's Medical Center. Over to Dr. Amrish to introduce the speakers for the day.
Thank you so much, Dr. Kalavani. On behalf of the Dr. Mehta's Children's Hospital in Chennai, India, the organizing committee, which has done a fabulous job in organizing these webinars, and my co-course director, Dr. Kalavani Ganeshan, we would welcome you all to this wonderful tubular disease symposium. Today, we have two excellent experts in the field of tubular disorders. And our first speaker is going to be Dr. Michelle Baum, who is the professor of pediatrics and internal medicine and associated vice chair of faculty development and endowed chair in pediatric research at University of Texas Southwestern Medical Center in Dallas, USA. Dr. Baum's research expertise is tubular disorders, tubular transport, and tubular maturation. He has described many transporters that explain differences between neonatal and adult kidney transport handling. He has been a section member of the National Institute of Health and won numerous awards. He has more than 150 publications. It's my honor, it's my privilege to welcome you, Dr. Baum. Over to you.
Thank you, Dr. Jain.
Kalavani, you can stop sharing. Yep, thank you.
I think you have to stop sharing, Dr. Jain.
I've stopped sharing, sir. You're able to share your screen?
I'm sharing mine, but I think Dr. Jain is, I think you are all sharing your screen as well.
I think we have stopped sharing.
Okay, I think I'm fine. Okay, well, thank you very much for the invitation. I'm going to be discussing some developmental changes in tubular transport. Well, we'll start at the beginning. You know that we are all endowed with.
Sorry to interrupt, sir. Your screen is not visible. We are not able to visualize your presentation.
Oops. I hit share screen and I'm seeing my screen. You cannot see it?
I think you would have opened in two windows. Probably I think you have to get through the other window because I remember seeing you on two windows. You can share your screen and.
Is that better?
Yeah, perfect.
Perfect.
Okay, great.
Thank you.
Again, thank you very much for the invitation to talk about developmental changes in tubular transport. So let's start at the beginning. We go through two kidneys before we get to the metanephros. We have a pronephros and mesonephros, which both involute. We start making urine at 10 weeks of gestational age. And this line here on top shows the increase in glomerular number as we mature in utero. And we continue to make nephrons until about 34 to 36 weeks gestation. There are a couple things that are important on this slide. First of all, there is an increasing number of infants that are born very prematurely. And those that are born at about 23, 24 weeks gestation have half of the nephron endowment, as does a mature infant that's born at 36 to 40 weeks gestation. Now, those babies who are born very premature still have nephrogenesis occurring, but the nephrogenesis only continues for about 10 days of age, and it's not clear whether or not those additional nephrons are functional. So these very, very premature infants we already recognize that they have some medical issues. We know that they have an increased likelihood of hypertension. And it's also clear now that there is an increased likelihood that they can have chronic kidney disease due to focal and segmental glomerular sclerosis. So while we're saving these very, very premature infants, they need to be followed carefully because of the likelihood of developing significant kidney disease. So at birth, a full-term baby has a glomerular filtration rate of 20 milliliters per minute per 1.73 meters squared. Now, if you don't factor it for surface area, a full-term baby only has a glomerular filtration rate of 2 milliliters per minute. So there's a huge maturational increase in glomerular filtration rate. And at 12 to 18 months of age, the glomerular filtration rate, when factored per meter squared, reaches the adult level of 100 to 120 milliliters per minute per 1.73 meters squared. So what we're going to do is we're going to walk down the nephron and look at the major salt reabsorptive segments of the kidney and discuss a little bit about how it matures. And then we're going to spend most of our time on the proximal tubule, where we have the most evidence for the changes in maturational transport. So this is the proximal tubule. We have sodium. There are actually 2 sodium glucose cotransporters on the proximal tubule and multiple sodium amino acid transporters. All these are electrogenic. The sodium is transported, which causes a lumen negative potential difference in the early proximal tubule, which allows chloride to pass through the paracellular pathway. Now, most of acidification occurs by NHE3. NHE3 is the sodium hydrogen exchanger 3, which is the third sodium hydrogen exchanger, which was uncovered. And in an adult, about 2/3 of bicarbonate absorption is via NHE3, and 1/3 is via a proton ATPase on the apical membrane. In the neonate, we have shown that there is no proton ATPase responsible for any acidification on the apical membrane. It's all due to the sodium hydrogen exchanger. Now, there's also a chloride base exchanger, and when this turns over, there is a net reabsorption of sodium and chloride and a net secretion of water. Now, 2/3 of sodium reabsorption occurs in the proximal tubule. The thick ascending limb is the other major salt reabsorptive segment. There is a sodium 2-chloride potassium cotransporter, which is bumetanide or furosemide sensitive. In parallel, there is a potassium secretion through a channel called ROMK, and this net neutral and then positive secretion causes a very positive luminal potential difference. And this is very important because this potential difference provides a driving force for magnesium and calcium absorption across the paracellular pathway. Now, this can occur because of the unique characteristics of the paracellular pathway in the thick ascending limb. There are claudins which are present in the thick ascending limb, which are rather unique. Claudin 16 and claudin 19 are both present, and they are responsible for a permeability to divalent cations, which is not present in any other epithelia. Then we move on to the distal convoluted tubule. Both the thick ascending limb and the distal convoluted tubule are water impermeable. So you're reabsorbing salt without water, which results in the adult of a urine osmolality of 50 milliosmoles per kilogram of water. And importantly, in the neonate can also dilute the urine to an equivalent amount. And this is important because the neonate is reabsorbed, is imbibing mother's milk. So it's without this ability to dilute your urine, that all infants would become extraordinarily hyponatremic. So this is the distal convoluted tubule. There's a sodium chloride cotransporter, which is sensitive to thiazide diuretics. Then finally, there's the collecting duct. So the collecting duct reabsorbs sodium and secretes potassium and protons. The potassium secretion is rather limited in the neonate and matures fairly quickly. The neonate also, while having an abundance of aldosterone circulating, is not sensitive to aldosterone, and very premature neonates have renal salt wasting if they're born before 32 weeks gestation because of the insensitivity to aldosterone secretion. Now, in terms of water, I mentioned that if there's no antidiuretic hormone, the urine will be excreted with a osmolality of 50. However, in the presence of aldosterone, a neonate can concentrate their urine to 600 milliosmoles per liter. This is in comparison, the adult can concentrate their urine up to 1200. This matures actually very quickly. So this is the collecting duct cell. There is an epithelial sodium channel, which causes a very negative potential difference. There's ROM-K, which is, again, a potassium channel, and its secretion is generated by this rather negative potential difference. This negative potential difference also causes chloride to move across the paracellular pathway. Both the potassium channel and the proton pump on the intercalated cells are very immature at birth, but mature rather quickly. So I'd like to talk about a couple of topics that are important in renal development and actually in adult kidneys as well. The first is glomerulotubular balance, and then we'll also talk about the threshold for reabsorption. Now, glomerulotubular balance is important because as the glomerular filtration rate increases in the neonate, there must be a parallel increase in the reabsorptive capacity of the tubules, and especially the proximal tubule, since it reabsorbs about 65% of the filtrate. Now, this is an example of glucose transport. in very premature infants born before 32 weeks gestation, there is glomerular tubular imbalance. And as you can see, they likely will have glucoseuria because the glomerular filtration rate or the glomerular delivery of glucose exceeds the tubular reabsorptive capacity. This is also true to some extent for salts, for sodium chloride, and many premature neonates need to be supplemented with sodium because they are salt wasters. Now we're going to talk about a little bit about threshold. Our sodium bicarbonate level is fixed at about 25 milliequivalents per liter. If we were to eat a lot of sodium bicarbonate, our bicarbonate level would increase very transiently above 25, maybe to 28 if we ate a lot of bicarbonate, and then it would rapidly fall. That is because you have exceeded the ability of the tubules to reabsorb all of the bicarbonate. That is what sets our serum bicarbonate level. It is the threshold above which we excrete bicarbonate. So for us, it is at 25. As we increase the filtrate of bicarbonate, we spill it. We only can reabsorb so much. And if we exceed that threshold, it is excreted. This is for a mature neonate or for an adult. But if you look at where the threshold is for a neonate, it's actually at a much lower level than it is for an adult, which is at 25 milliequivalents per liter. A normal premature neonate can have a serum bicarbonate of 14.5, and that may be the normal threshold for that infant until there is maturational increase in sodium bicarbonate reabsorption. So we're going to be talking from here on in about the maturation of proximal tubule acidification, because that is the segment where most of the knowledge of tubular maturation has been worked out. So this slide depicts the amount of sodium hydrogen exchange activity in the proximal tubule. This is an adult, and as you can see, there is abundant sodium hydrogen exchange activity. And if you add amiloride or ethyl isopropyl amiloride, the level drops because the sodium hydrogen exchanger is inhibited by ethyl isopropyl amiloride. The importance is that the neonate is much lower than the adult, but it's also inhibited by amiloride analogs. So this is mRNA abundance of NHE3. And as you can see, there's almost none until about 2 weeks of age. And then you have a robust increase in sodium hydrogen exchange mRNA. The same is true of protein. You don't have any sodium hydrogen exchange, NHE3, protein abundance, and this is brush border membranes where all the sodium hydrogen exchangers are housed. And as you can see, there's a huge maturational increase and virtually none in the very young animals. So why do I show this? It's because you have, these are the very young animals that I'm depicting right here. They have no NHE3, but yet they have an abundance, while less than the adult, they still have an abundance of sodium hydrogen exchange activity. So I found this very interesting and a little disturbing because I had no idea what was causing this sodium hydrogen exchange activity. So we pursued this. We said, maybe there's another sodium hydrogen exchanger. And in order to answer that question, I took mice that were normal control mice and saw that they had abundant sodium hydrogen exchange activity. It was inhibited by amiloride. Then I studied NHE3 knockout mice. These mice have no NHE3, but yet have abundant sodium hydrogen exchange activity. So if you look here, this is a control mice on the right-hand side of the screen, when you remove sodium, there's a rapid cell acidification. When you add sodium back, there's a rapid alkalinization. And this is all due to the sodium hydrogen exchanger. In NHE3 knockout mice shown below it, there still is sodium hydrogen exchange activity, even though there is no NHE3. So we thought that there had to be another sodium hydrogen exchanger. And at about the same time, a colleague at Yale, Peter Aronson, had found another sodium hydrogen exchanger called NHE8, but it was unclear what NHE8 was doing. So we started working together because I thought this was the sodium hydrogen exchanger that is present in the newborn and not present in the adult. So looking at sodium hydrogen exchange activity 3, as I've already shown you, on the right-hand side, there's a maturational increase, and it's depicted below as well. On the left-hand side is NHE8, and as you can see below and on the Western blot above, there is an abundance of NHE8 when there is very, very little or no NHE3. In other words, there is an isoform switch, something that had never been thought to occur, or at least I never thought would occur, but actually there are maturational changes in transporters as we develop. Now, NHE8, just to prove the point, is shown here. It's on the apical membrane of the proximal tubule, just as we would expect. So we took it a little bit further. These are, on the left-hand side, is a control mouse that has NHE3 and NHE8. Now, these are adult mice. Next to it is an NHE8 knockout mice. And as you can see, the sodium hydrogen exchange activity is the same as in the control mouse. And that's because NHE8 doesn't play any role in the adult. And we look at the sodium hydrogen exchanger in NHE3 knockout mice, there is NHE8 then becomes an important player in this and takes over for some of the NHE3. And when we look at a double knockout mice, all the way on the right, there's virtually no sodium hydrogen exchange activity. There's a little bit here, but I'm not sure what that's due to. So we next asked, what is causing this? What is causing a maturational increase in NHE3 and decrease in NHE8? Our thought was it's probably the changes that occur in postnatal hormones. If you look at rodents, there's an increase in thyroid hormone and glucocorticoids, which occur at the same time that this maturational exchange is occurring. So we thought that that is more than a coincidence, that maybe this is causing the changes in NHE3 and NHE8. So here's what we did. We looked at NHE3 in a 9-day-old, and the reason why you can see it is this is a very overexpressed film. And then we looked at an adrenalectomized hypothyroid mature rat. And as you can see, there's virtually the same amount of NHE3. We inhibited the maturational increase. When we added glucocorticoids and thyroid hormone, we increased the abundance to the same amount as in the sham animal. So either thyroid hormone or glucocorticoids was likely the cause for the maturational increase in NHE3. Above, this is mRNA abundance, and we show the same thing here with protein abundance on brush border membranes. So this shows the same thing. This is a 9-day-old animal. This is an adrenalectomized animal. This is the adrenalized hypothyroid 30-day-old animal. And that when we add, this is sodium hydrogen exchange activity. And when we administer glucocorticoids and thyroid hormone, we get the same amount all the way as the sham animal on the right. So therefore, either thyroid hormone or glucocorticoids is likely the cause of the maturational increase in NHE3. So, as I said, there was a maturational increase in NHE3. There must be a cause for the decrease in NHE8. So we looked at the isoform switch in neonates. This is a control animal, and when we gave, this is a neonate, and on the right-hand side, when we gave thyroid hormone, we accelerated the maturational increase in the neonate. When we gave thyroid hormone to the neonate, we actually caused a maturational decrease in NHE8. In other words, it looks like this is what's causing the isoform switch. Now, to prove this, we took adults and we made them hypothyroids since they were neonates. And as you can see, if you prevent the maturational increase in thyroid hormone in these adults, they don't have an increase in NHE3. Whereas in these adults, they don't have a maturational decrease in NHE8. So we have here a developmental isoform switch, and we have figured out that it's probably thyroid hormone which is causing this switch. So I'd like to change here a little bit and talk about the paracellular pathway, something that we really don't think about. But the paracellular pathway is a way of getting something for free, something for nothing. And here's how. All along the nephron, we have gradients for ions and for solutes. The thing that causes any selectivity for diffusion of these solutes is the tight junction right here. Now, the tight junction is made up of occludin, which isn't very selective and is in all paracellular pathways. But what causes the selectivity are these claudins. And claudins hold hands with the cell next to it. And that causes a selectivity of the paracellular pathway depending upon which claudins are present. So for example, in the thick ascending limb, you have unique claudins, claudin 16 and 19, which allow the paracellular pathway to absorb magnesium and calcium ions. But we're going to focus on the proximal tubule because it has unique paracellular pathway changes that occur during maturation. This is the proximal tubule. What we want is to get something for nothing. There are chloride gradients that occur during the proximal tubule, because there is a preferential reabsorption of bicarbonate and a higher chloride concentration in the lumen than in the blood. And chloride could theoretically pass across the paracellular pathway and drag sodium with it. This is the thick ascending limb again that allows magnesium and calcium to go across because of claudin 16 and 19. And then all the way on the right is the distal tubule, which allows chloride to be reabsorbed because of the large lumen negative potential caused by the sodium transport. So looking again at the proximal tubule, there are two things that can cause chloride absorption. One is the preferential reabsorption of bicarbonate leaves a higher chloride reabsorptive, higher luminal chloride concentration than the blood. It's about 20 milliequivalents higher. So there's a large gradient for chloride to move passively across the paracellular pathway. In addition, the lumen negative potential difference caused by organic transport also causes a potential for chloride to be reabsorbed across the paracellular pathway. Now, thinking about it, I predicted that what was going to occur is that the neonate, which is very immature, would have a very leaky epithelium. And this is a way where we could get a lot of something for nothing. We could reabsorb sodium chloride across the paracellular pathway without expending any energy because of the proximal tubule reabsorption of other solutes. So we looked at all the claudins that are involved. And as you can see in the kidney of the adult, there's an abundance of various claudins. But what was interesting to us is that there was claudin 6 and claudin 9 and a little bit of claudin 13 in the neonatal tubule that wasn't present in the adult. So that's rather strange. Why would there be other claudins there? Why would there be a developmental switch in the number of claudins on the proximal tubule? Well, we started looking at the paracellular characteristics of transport in the neonate compared to the adult. And when we looked at mannitol permeability, which is a non-transported sugar, and put mannitol in the lumen and looked at how much disappeared, and that allowed us to look at the permeability of mannitol, they were identical. There was no difference. When we looked at chloride, I was completely wrong. The adult has a lot of passive chloride absorption. It is getting something for nothing during maturation. It's becoming chloride permeable, whereas the neonate, which I thought would be very permeable, is totally impermeable to chloride. So as the chloride gradient occurs and that lumen negative potential allows chloride diffusion in the adult, you're not getting something for nothing in the neonate. There is no passive chloride absorption. When we looked at the resistance of the epithelium, again, it's exactly the opposite of what I thought. The neonate is actually a much tighter epithelium when you look at the resistance compared to the adult. So what causes the developmental change in paracellular permeability? When we looked at claudin 6, which is not present in the adult, this is mRNA abundance, we see it in the neonate, not in the adult. And when we looked at protein expression, we see just a tad in the adult, but a very highly expressed in the neonate. This is one of the claudins that was present in the neonate that we found that is not present or barely present in the adult. Again, this is a paracellular protein. When we looked at it in the this is the adult on the right and the neonate on the left. Claudin 6 is between cells. This is causing in the paracellular pathway. There is none in the adult that's visible. So we wanted to see if Claudin 6 and Claudin 9 are really causing changes in paracellular permeability. Again, they're present in the neonate, they're not present in the adult. And when we look at this, in order to study this, we had to take cells, MDCK cells, which don't have Claudin 6 or Claudin 9, and put Claudin 6 and Claudin 9 into those cells. And that's depicted on the red above. This is transfected cells that now are expressing these proteins, whereas they didn't before. And as you can see, they're around the cells, not in the cells. And as you can see here, we have on the bottom, we have high expression of Claudin 6 and Claudin 9 in these transfected cells. So what is it doing? It is increasing the resistance, just as the neonatal tubules had an increase in resistance. Those transfected with Claudin 6 and Claudin 9 have an increase in resistance. And when we look at chloride permeability, which is really what we were trying to figure out, why there's such a decrease in chloride permeability in the neonate, we find that the control has a much higher permeability to chloride, and the Claudin 6 and Claudin 9, when expressed in these cells, obliterate or decrease chloride permeability. So in conclusion, neonatal transport is balanced by a lower rate of GFR and tubular reabsorption. However, in very premature infants, glomerular tubular balance doesn't quite hold. There is an increase in glomerular filtration rate that exceeds the delivery that can be transported in the neonatal tubules. We show that there are developmental changes in tubular transport, and that neonatal tubules are not just smaller tubules with lower rates of transport, but actually have maturational changes in transporters and in the paracellular proteins that affect net transport. And thank you for your attention.
Thank you so much, Dr. Baum, for so simplifying the difference between the neonatal kidney and the adult kidney. Thank you so much for sharing all your research and your insight. We will have questions at the end of the second talk. And for the next talk, I would like to introduce Dr. Indira Agarwal. She's the head of the department and professor of pediatrics at Christian Medical College, Vellore, India. Her clinical and research interests include glomerular and tubular disorders. She's the past president of Indian Society of Pediatric Nephrology. She's on the scientific advisory board to the National Board in Pediatric Nephrology. She has been actively involved with Indian Society of Nephrology, with Sister Renal program and the transplant program. And she has more than 120 publications. It's an honor to welcome Dr. Indira Agarwal. Over to you, ma'am.
Yeah, thank you, Dr. Kalevani and Dr. Amrish, for inviting me here today to give this talk. I just want to say I'm not able to share my screen, I think, till Dr.
Amrish, Dr. Bond, can you stop sharing your screen?
Dr. Baum, I think it's you sharing the screen.
Oh, no.
If you could stop it.
Did I do it?
Yes.
Yep.
Perfect.
Thank you so much.
Thank you. Sorry.
Yeah, that's fine. Yeah. So can you see my screen?
No, ma'am.
No, is it?
No.
Oh, why is it not? I was able to share it. Sorry. Now I think I can see only your screen, Kalevani. I'm not able to share it. Now, tell me. Can you see it now?
Yep, we can see it now.
So I'll put it on full screen.
And full screen, ma'am. You have to go to the slideshow.
Okay, slideshow, is it? Okay. So is that under the screen share itself? No, I'll just go to slideshow. Yeah. Is it okay now?
That's great. Thank you.
So now from that excellent talk by Dr. Michael Baum, where he very interestingly talked about various parts of tubular physiology, we will go to another clinical condition called nephrocalcinosis, which all of us have dealt with, associated with various tubular disorders in our clinical practice. So this will be a little more of a clinical talk, and let's just see how we can improve our understanding on nephrocalcinosis. So during this talk, I will be giving a brief introduction about it, the definition, causes, some case scenarios, a little bit of the pathophysiology, evaluation, treatment, and outcome. So what is nephrocalcinosis? It is characterized by, very simply, the deposition of calcium in the kidney parenchyma and the tubules. And it may occur as a result of either acute or chronic kidney injury, or it may be just incidentally picked up radiologically in a patient who actually has normal kidney function. It can be caused by multiple different conditions, and the prognosis actually depends on what the underlying cause is. And whereas most patients with nephrocalcinosis do not progress to end-stage kidney disease, some conditions which not effectively treated could still be associated with progressive kidney dysfunction. So it's very important that we identify it and find out what is the underlying cause that is associated with nephrocalcinosis so that we can have a good outcome. So by definition, the nephrocalcinosis actually describes the deposition of both calcium oxalate and calcium phosphate. If it refers to only calcium oxalate, it is actually called oxalosis, and it refers to only calcium oxalate deposition. And sometimes we may find localized calcium deposition in the kidney, which may occur secondary to some kidney injury. It is actually not considered to be the same as nephrocalcinosis. So in order to understand this, we need to know that nephrocalcinosis is very closely linked to the calcium metabolism and often related to some dysregulation that is occurring in the tubular transport or the absorption of calcium. And therefore, to start with, the first thing that we'd like to understand is where all calcium is absorbed. And as we know, majority of this, 65% is absorbed in the proximal tubule and about 25% from the thick ascending loop of Henle. Only 10% is absorbed in the distal convoluted tubule and 5% in the cortical collecting duct. Now, at these sites of absorption, there are multiple genetic mutations that can occur, or mutations in the protein or the transport of calcium that can occur, and all the associated salts that are absorbed at the same place. This can result in various clinical conditions, and therefore the monogenic causes of nephrocalcinosis are actually quite important for us to understand, and which might actually give us an insight into the pathogenesis. Another interesting point is that though 15% of calcium is absorbed along the DCT and the cortical duct, there are practically no clinical conditions that are associated with this defect in transport in this region. And we do not really see much of nephrocalcinosis from these areas. Now about the pathogenesis. So nephrocalcinosis, as we said, is caused by increased excretion of not only calcium, but also of phosphate and oxalate. And the most common cause is actually the urinary calcium excretion, which is actually more important than the other two. And it may or may not be associated with hypercalcemia. And these metabolic abnormalities may be either closely associated with nephrolithiasis, and many children will have both nephrocalcinosis as well as nephrolithiasis. However, there are some conditions where only nephrocalcinosis may occur and there's no nephrolithiasis. And then the reverse is also true, where nephrolithiasis may be present in the absence of nephrocalcinosis. However, we must just remember that nephrocalcinosis often suggests a very serious metabolic defect, whereas conditions that are associated with nephrolithiasis in themselves may actually be observed in many healthy individuals. So nephrocalcinosis per se generally suggests a much more severe and serious underlying abnormality. Now, when we look at these three conditions, hypercalciuria, nephrolithiasis, and nephrocalcinosis, they're all closely interlinked with each other. But the problems start when there are defects in the epithelial and paracellular disturbances which are affecting the calcium absorption. And this results ultimately in the increase in the calcium levels as hypercalcemia. They also may be at the same time, we may see increase in phosphate levels. Now, when this occurs, there is a precipitation of calcium crystals within the urine, and therefore this results in, could increase the risk for stone formation or nephrolithiasis. Now, many times nephrolithiasis may also be associated with nephrocalcinosis because all this excess calcium gets deposited either within the tubules or within the interstitium that is present within the kidney. So medullary nephrocalcinosis often occurs as a consequence of hypercalciuria and is closely linked to it. And it also, there is a predisposition to stone formation. Now, both nephrocalcinosis and nephrolithiasis can coexist in many of these monogenic conditions that can occur. And sometimes nephrolithiasis may occur in isolation, but during the evaluation of nephrolithiasis, we may actually uncover the presence of not only nephrocalcinosis, but some of the inherited conditions that are associated with it. And this is how we can demonstrate the presence of nephrocalcinosis in the kidney. You can see this dense calcium, the deposition that is generally bilaterally symmetrical and generally present in the papillae of in the medulla of the kidney. And this can be graded from about 1 to 3, depending on the severity of the echogenicity. Now, how do we classify nephrocalcinosis? There are actually 3 different types that we know. There is one molecular, there is a microscopic nephrocalcinosis, and the third and the most common one that we actually deal with is the macroscopic type. The molecular or the chemical nephrocalcinosis, as the name suggests, is just an increase in the intracellular calcium concentration, which is actually neither visible microscopically nor is it visible by radiographic imaging. There's no crystal formation, and it just reflects early changes of calcium dysregulation. So it is actually reversible. When the hypercalcemia corrects, it is reversible. So many times we are not able to actually detect this condition. Now we have then the second type is a microscopic nephrocalcinosis. Now, as the name suggests, these are mineral deposits that are visible on light microscopic examination of the tissue, which we may be obtained by biopsy, but it is not picked up by radiographic imaging. So this may be many times incidentally picked up because nephrocalcinosis per se does not really warrant a renal biopsy unless it is very, very specifically indicated. But what is important, it may be a precursor of microscopic nephrocalcinosis. And also sometimes we may see it in very acutely, there may be calcium deposition and phosphate deposition of a phosphate nephropathy, as it's called. When we use things like sodium phosphate preparations, which may be used for bowel cleansing agents, and there may be an acute rise in this sodium phosphate concentration, which might then get deposited in the kidney, and therefore may be visible as a microscopic nephrocalcinosis. It is a macroscopic type, which is the one we deal with in our day-to-day practice, and this is visible by radiographic imaging. So very simply put, there's some reason for increase in the calcium levels. This may be either by enhanced absorption of calcium from the gut, or they may be from impaired renal handling of calcium in the kidneys. So both these conditions would lead to hypercalciuria and also development of nephrocalcinosis. So this can further be divided based on the site of nephrocalcinosis. And so we have 2 types. One is the cortical nephrocalcinosis and the other is the medullary nephrocalcinosis. Now, cortical nephrocalcinosis actually is very rarely seen and reported to be only about 2.4% of cases. But this present after very severe destructive changes may occur in the cortex. And this can occur after very chronic glomerulonephritis or a chronic pyelonephritis or acute cortical necrosis, sometimes from trauma or even ARPKD may see a localized cortical nephrocalcinosis may be sometimes seen. Or it also seen in post-transplant patients when there is renal allograft dysfunction. So majority of the patients that we do see are 97% of them actually have medullary nephrocalcinosis. And the site where it often starts developing is from the thick ascending loop of Henle, as well as the collecting duct where the acid-base imbalance occurs, where a lot of the homeostatic pathways of calcium absorption are present. Coming to what are the promoters of nephrocalcinosis. So calcium phosphate plaques can often be formed once there's increase in calcium phosphate concentration, and then these enlarge and they may either get deposited in the interstitial tissue or they may rupture into the tubules. And once they are ruptured in the lumen, they form a nidus for the calcium oxalate crystal formation and stone formation to occur. Oxalate crystals, on the other hand, are of two types. They may be either homogeneous, where they're composed of calcium and oxalate, or they may be heterogeneous, where they're composed of calcium oxalate as well as phosphate. The same homogenic calcium oxalate, as we know, would go on to form hyperoxaluria because of mainly containing oxalate, and they are what we see when there is primary hyperoxaluria or when there's ethylene glycol toxicity. The heterogeneous crystals, as they contain many types of crystals, may actually present with milder degrees of hyperoxaluria. Now, this looking deeper into the nephrocalcinosis, they may this nephrocalcinosis might actually occur in the tubules or it may occur in the interstitium. Now, when tubular nephrocalcinosis occurs, it actually, there is first tubular crystal formation, and these then get deposited at these tubular cells, which initially are injured and inflamed, and then they get flattened. So these crystals very easily get adhered to these tubular cells, and then they start increasing in size and often end up blocking the tubular lumen after this aggregation, and crystals may later go on to form actually plaques. Now, when in the interstitium, when most of it, actually the nephrocalcinosis is actually found in the interstitium, and it is results in the formation of these Renal plaques, which are found in the papilla of these in the medulla. And it starts with these interstitial apatite crystals, which get deposited first in the basal membrane of the thin ascending loop of Henle, and then they extend into the interstitium, into the papillary area, and then it increases in size, and it forms again the nidus for calcium oxalate deposition. So calcium oxalate generally overlies and adheres to these plaques and results in the formation of these nephrocalcinosis. Now, there are some promoters and some inhibitors of nephrocalcinosis. So anything that can promote hyperoxaluria will promote nephrocalcinosis or hyperoxaluria, and there are some miscellaneous causes. So for nephrocalcinosis, hyperoxaluria will be associated with acidosis, high calcium intake, low phosphate intake, parenteral nutrition, loop diuretics, vitamin D. Whereas hyperoxaluria may be related to a high precursor intake of ascorbic acid, lysine, parenteral nutrition, secondary hyperoxaluria when there's increased absorption from the gut, fat malabsorption, or even high phosphorus intake. And also miscellaneous causes which may be associated with family history and a tendency to have nephrocalcinosis, or sometimes even use of nephrotoxic medication. And amongst the inhibitors of nephrocalcinosis, we have thiazide, citrate, even magnesium may probably play a role, osteopontin, nephrocalcin, and even possibly TAM-phosphol proteins. So this dysregulation of calcium homeostasis, there are many monogenic causes, and some various genes have been identified. One of the many is the FAM20A gene, but there are many more which are secreted this is secreted in the saliva and the bloodstream. So again, when the plasma calcium increases, there's increased absorption of calcium which occurs in the tubules and in both in the proximal distal tubule as well as the thick ascending loop. And then it then gets absorbed into the cells and moves into the interstitium. So this increased flux of calcium across the renal tubular epithelial, then it goes into the interstitium. And there are some inhibitors that are present like Pheto-NA, matrix, G1A protein, the osteoproteogerin, and pyrophosphate. So these actually work to inhibit this precipitation, whereas if there's dysregulation of this pathway, then again, there may be increased risk of nephrocalcinosis. So it is an interplay between the calcium promoters and the inhibitors, which may play an important role in the development of nephrocalcinosis. Now, though histopathology is not really required routinely in the diagnosis of nephrocalcinosis, but sometimes it may have been done for the diagnosis of other related conditions. And so some of the findings that we may see in a kidney biopsy may be presence of nephrocalcinosis that is seen in the tubular, intracellular, and interstitial areas where calcification may be seen. And calcium phosphate may be distinguished from calcium oxalate by specifically staining with the Van Cos stain. And there's also another point, there's absence of birefringence under polarized light, which will distinguish this phosphate from oxalate. In addition to this, you may also see tubular atrophy, interstitial fibrosis, interstitial inflammation with lymphocyte infiltration, which may accompany this calcium phosphate and oxalate deposition. Now, coming to what are the risk factors for nephrocalcinosis. So it is definitely associated with the conditions, with the metabolic changes that occur. So it may be associated with hypercalcemia and hyperphosphatemia, and also with the increased urinary the excretion of calcium phosphate and oxalate. So both these conditions may have a role to play. Hypocitraturia also plays another very important role, especially in when there is distal RTA. And it promotes the formation of stones, especially when there is hypercalciuria. In addition to these, there are various genetic abnormalities, anatomic abnormalities, metabolic disturbances, and even UTIs, which may play a role in the development of nephrocalcinosis. Now, just to mention that there are various, what are the different promoters and inhibitors, there's a whole list of them that may be there, and to mention a few: TAM phosphoprotein, osteopontin, the pre-thrombin fragment 1, and you can see the list. Many of these are inhibitors, as well as you have some promoters of nephrocalcinosis like CD44 and osteonectin, which may promote this calcium oxide crystallization and formation of renal stones. Now, looking at the causes of nephrocalcinosis, which may be the different conditions that may be associated with this, and these may be classified into different ways. So the first set is when there's hypercalciuria associated with hypercalcemia, where you may have primary hyperparathyroidism, sarcoidosis, or vitamin D toxicity. Then you have the group where there's hypercalciuria without hypercalcemia, and these are conditions like distal RTA, medullary sponge kidney, and neonatal nephrocalcinosis. And then there are some conditions with just hyperphosphaturia, which may be associated with the formation of nephrocalcinosis. So it's not really possible to go into the depths of all these conditions, and some of these have been also already covered in previous talks. But just to run through a few points about these conditions. So primary hyperparathyroidism is associated with both nephrocalcinosis and nephrolithiasis, and one of the most common kidney manifestations that may be seen in this hyperparathyroidism, and it may be seen in about 16 to 22% of these patients. Now, sarcoidosis is a granulomatous disorder, which is quite a chronic condition, and we know it is associated with hypercalcemia, hypercalciuria, and there may often be also nephrocalcinosis. And the other conditions that points that may promote this is the hyperabsorption of dietary calcium, which may occur in 50% of these cases. It can also occur with hypercalcemia, with hypercalciuria without hypercalcemia. Now, vitamin D therapy itself can sort of over aggressive treatment with vitamin D preparations can also increase the absorption of calcium from the gut, and also called bone resorption, which could result in increased hypercalciuria. Also, when calcitriol is co-administered with oral phosphate, and sometimes if it is not closely monitored, it may also result in, if you sort of treat with calcitriol in conditions with like X-linked hypophosphatemic rickets, you may also end up with nephrocalcinosis, and therefore this needs to be monitored. Now, the most common condition that is associated with hypercalciuria and without hypocalcemia is distal renal tubular acidosis, which is one of the most common causes of nephrocalcinosis that we see in our practice, and it is associated with systemic acidosis, and this occurs because of the increased buffering of acid by the bone and release of bone calcium and phosphate, which will then predispose to nephrocalcinosis. There's also because of the coexistence of hypocitraturia, which can also promote the calcium precipitation in the tubules, and the high alkaline pH, which is present in distal RTA, will also cause these two conditions, and it may be present in as high as 60 to 80% of all children with distal RTA. I'll just take a brief break here and go through a case scenario. A 2-month-old child was referred from a peripheral hospital. This was an ex-preterm child at 34 weeks and had quite a stormy neonatal period, and had HMD and had PDA, received oxygen for several days, also received treatment for congestive cardiac failure, furosemide was used, and for brief periods. So this child finally recovered and was gaining weight slowly. But the treating doctors actually, pediatricians actually noted that the child actually had a low sodium, lowish potassium, bicarb, which is on the lower side, and a calcium creatinine of about 0.4, which maybe is not really very high for this baby. But at the same time, nephrocalcinosis was noted. And so it seemed a little unusual. Why should this child have nephrocalcinosis when everything seemed more or less okay? So the child was voiding well, the blood test seemed okay. And when we discussed with the radiologists, they thought that possibly a medullary calcinosis could be present, but there could also be a possibility of a TAM phosphoproteinuria, which could be appearing to be like medullary nephrocalcinosis. So no treatment was given. The child was followed up, and 6 months later, the child had actually a normal ultrasound. So neonatal nephrocalcinosis is something that we do see quite commonly in babies who are of low birth weight, and it has a reported incidence almost of 60% in infants with a birth weight below 1500 grams. And the most common cause is the administration of loop diuretics and furosemide, but less common causes may also be present, maybe due to Williams syndrome, where they have hypercalcemia, aortic stenosis, which may also then be associated with nephrocalcinosis. It could be an early onset renal tubular acidosis, and this should not be missed out and should definitely be screened for and not taken for granted that it is a non-specific complication due to furosemide. And of course, it could also be due to primarily neonatal hypoparathyroidism. So all these conditions need to be thought of. And one of the reasons why this may occur is that premature kidneys have very long loops of Henle. And so there is a very low urine velocity. And this could result in very easily crystal aggregation in the tubules. And then this could lead to increased deposition in the interstitium. So there's also a reduction in the passive calcium reabsorption that occurs. And what is interesting is that there's often spontaneous resolution that occurs over a period of time. Now, in case this is due to a calyceal deposition of TAM protein, even this is a very harmless condition, but it may mimic nephrocalcinosis in preterm neonates, but is also known to be reversible and gradually disappear with time. Now, to a few more case scenarios, just to go over the conditions that are commonly associated with nephrocalcinosis, not going into the details because many of these have already been discussed. So there's a 3-year-old child who came with failure to thrive, polyuria, polydipsia. There was a history of diarrheal episodes in the past associated with rapid breathing and feeling of weakness. And the test showed hypokalemic metabolic acidosis, ultrasound showed nephrocalcinosis. So most likely this must have been a distal RTA. Then the 1-year-old child came with poor weight gain. There was a history of drinking lots of water and voiding very frequently. The child was brought with extreme lethargy and after viral illness. And tests showed that the sodium was 118, potassium 1.9, chloride 88, bicarb 39. Ultrasound showed normal sized kidneys and the child had nephrocalcinosis. So probably likely a Bartter syndrome. Then another 5-month-old brought with poor weight gain, frequent febrile episodes, had a preference to water than breast milk, according to the mother, would drink water avidly, also had a salty kiss. And so the tests and also gave intermittent, the febrile episodes that I mentioned. So the sodium was reported to be 160, potassium was 3.6, chloride was 104, and the bicarb 24. Serum osmolality was high at 305, the low urine osmolality at 154, and the USG showed nephrocalcinosis. So this a condition that was only recently discussed, which is nephrogenic DI. Sorry, not nephrogenic DI, diabetes insipidus, and which needs to be evaluated further. Then we had a 4-month-old child, a slightly different kind of scenario, thriving very well, and visited the doctor for abdominal pain. Ultrasound showed bilateral nephrocalcinosis. So this came as a surprise. And so the child was referred to the nephrologist. And so the nephrologist, this child actually came to us. And so there was a doubt, is this really nephrocalcinosis or is it something else? And so our radiologist felt that we should rule out this thing, medullary sponge kidney, and asked us to do an IV and a CT. And this possibly showed that this could be a developing medullary sponge kidney. So what do we know about medullary sponge kidney? Nephrocalcinosis is often observed in these children radiographically in 30 to 50% of these patients. And it occurs due to cystic dilatation of the tubules, and it may be associated with a radiological finding of a tumor blush that is very typically seen in an IVU, may also be seen in a CT scan that may be done, and it is caused with contrast, and it is caused by pooling of contrast. But the interesting thing is that medullary sponge kidney doesn't usually present very early. It may be actually picked up a little later in life, maybe sometime in the end of the first decade. And often it is due to the presence of ectatic precalicial collecting ducts. And these also by development, it's caused by disruption of the normal ureteric bud and metanephric interface. So it is characterized by hypocytruria, which contributes to the development of nephrocalcinosis and hypercalciuria. And they also might have some proximal tubular dysfunction and acidification defects. And they are very prone to stone formation, especially in the inner medullary region and in the collecting duct, which actually may plug these regions with these stones. Now coming to the other inherited tubulopathies, and some of these disorders may be associated with just isolated hypercalciuria, whereas some may be having both hypercalciuria as well as hyperphosphaturia. So the ones with just isolated hypercalciuria, we know Bartter syndrome, hypomagnesic, hypercalciuric nephrocalcinosis, autosomal dominant hypocalcemia, and also following inherited diseases where there is both hypercalciuria and hyperphosphaturia, and this consists of Dense disease and Lewis syndrome. So again, in the interest of time, we can't, there's not enough time to go through these conditions, but just to familiarize and probably recap where these conditions are actually where the dysfunction is noted. So we have the Dense disease and the Lewis syndrome, which is disorders present of these proteins and genetic mutations, which are seen in the proximal tubule. We have Bartter syndrome, and we just talked about Claudin 16 and 19, and the calcium sensing receptors, both the activating mutations as well as inactivating mutations, which are seen in the thick ascending loop of Henle. Then we also have the other hypomagnesic disorders, which were discussed just last week, and all the various proteins and the mutations that are associated with them, which are generally associated with the distal convoluted tubule. And then we have the collecting duct, where you have distal renal tubular acidosis and pseudo hypoaldosteronism. And these are some of the genes and the proteins that are associated with these conditions. So there's not really enough time to go through them, but practically with the onset of now free availability of genetic studies, we are much easily able to classify these conditions and confirm diagnosis more effectively. And this definitely helps in treating these conditions. Now we have another set of conditions that are associated with chronic hypokalemia and associated with nephrocalcinosis. And primarily amongst these is primary hypoaldosteronism and Liddle syndrome. Now, when there is nephrocalcinosis and hyperkalemia and no and associated hypercalciuria, you also see the distal RTA and Bartter syndrome, which also associated similarly. However, in Gitelman syndrome, where there's a mutation in the thiazide-sensitive chloride channels in the distal tubule, there is hypocalciuria, but there is no nephrocalcinosis. Now, some of the conditions that are associated with hyperphosphaturia, they may be present with hypercalciuria, and there may be development of nephrocalcinosis. Now, when you have hyperphosphaturia associated with hyperphosphatemia also, there is often acute kidney injury, and there's tumor lysis syndrome, which we often come across, and also ingestion of oral sodium phosphate during bowel preps. But in these conditions, these are very acute, and therefore you may see only microscopic nephrocalcinosis. And since most of these are very easily treatable and reversible, we don't really see the typical medullary nephrocalcinosis. Then also you can have hyperphosphaturia in the absence of hyperphosphatemia, but these are associated with various inherited tubulopathies, and they may also associated with malignancy and kidney transplantation. Then you can have just hyperphosphaturia just as an isolated abnormality. There may or may not be hypercalciuria, and here these are these diseases like Dense and Lewis syndrome. And then you have inherited tubular defects that cause both phosphaturia, and again there's no hypercalciuria, hypercalciuria, and these are like the X-linked hypophosphatemic rickets and also the autosomal dominant and recessive hypophosphatemic rickets. Now again about hyperoxaluria, which is again a major cause of nephrocalcinosis and nephrolithiasis, but again won't be going into the details as we possibly have a talk which might follow in the subsequent sessions. But here we have, it's a major risk factor, as we know, for the development of oxalosis, because it's a very poorly soluble, oxalate is very poorly soluble and therefore very easily results in nephrocalcinosis and nephrolithiasis. Now, it is an autosomal recessive disorder and that may occur due to increased synthesis of oxalate, or it is due to increased enteric absorption of oxalate. When there is defective liver enzymes involved in the glycoxylate mechanism, there is increased production of oxalate. When there is fat malabsorption, is one of the most important causes and most common causes when there's increased absorption of oxalate in the gut via the calcium. Why? Because it binds to calcium by the free fatty acids that are present in the colon. And with the genetic basis, we know that the AGXT mutation, the GRHPR, HOGA1 mutations, and the SLIC26A1 mutations, which are associated with these different inherited disorders, which may occur of varying severity. Now, nephrocalcinosis can also occur in other clinical settings, which are not really related directly to these calcium, the renal conditions. So there can be pancreatic insufficiency, inflammatory bowel disease, bowel resection, jejunal or gastric bypass. Sometimes some drugs can cause fat malabsorption by inhibiting gastric and pancreatic lipases. Also cystic fibrosis, which also causes pancreatic insufficiency. So all these can also result in nephrocalcinosis by promoting calcium deposition, as well as presence of hypercalciuria, which will promote this. Now, what is a clinical presentation of nephrocalcinosis? Often the nephrocalcinosis per se may be asymptomatic, and the symptoms that you see may be associated with the clinical condition that it is primarily involved in. But it is a slowly growing progressive disease and may also be just an incidental finding by radiography in the abdomen, and therefore it really may be actually just picked up incidentally. So it is, but it is a part of evaluation when there is presence of nephrolithiasis, which coexist with nephrocalcinosis. And occasionally, so as I said, the symptoms may be due to the underlying condition. So for example, if you have renal colic and polyuria and polydipsia, maybe some of the symptoms that may be associated with it. Renal colic is associated with nephrolithiasis and associated with chronic hypercalciuria, whereas nocturia, polyuria, polydipsia generally represent an impaired concentrating ability, and therefore we may have to look for what is the underlying tubular disorder associated with it. And some are typically, they are acute and present in even kidney failure. So the diagnosis, so we have to consider the whole gamut of differential diagnosis that we have talked about in the last few slides. But in some conditions, it may also be present with chronic kidney disease. If there's a bland urine with little or no proteinuria, and we don't really know what the underlying cause is, and but there is hypercalcemia, then we definitely need to look for nephrocalcinosis and then try to find out what is the underlying cause. And chronic nephrocalcinosis can be picked up only by imaging and very rarely by kidney biopsy if it is indicated, but it's not a routine requirement to diagnose nephrocalcinosis. And therefore, as reiterating that nephrocalcinosis may be an incidental finding when it may be performed for an indication which may be even unrelated to the kidney. For example, if you're evaluating nephrocalcinosis condition like cystic fibrosis or pancreatic insufficiency, or it may actually be done as a part of evaluation for nephrolithiasis per se. So as mentioned to you earlier, it is only macroscopic nephrocalcinosis which is picked up by imaging techniques. And if it is very severe, it may be even picked up by an abnormal X-ray. But the other techniques, and the one which is most commonly used, is probably the ultrasound. And CT is also a very good method of picking up nephrocalcinosis. However, actually MRI actually is a very poor modality to pick up calcification in the kidney. So though there's limited data that's available on this, but definitely ultrasound and CT are the most sensitive methods to pick up nephrocalcinosis, and especially when it may be an early finding even in those who have mild disease. Now, just to talk about one particular radiological mimic, there was a 14-year-old child with a second-degree consanguineous marriage who was actually thriving well, but was referred with recurrent abdominal pain, which has been occurring for several years. So on examination, he also had some atypical features. He had some hypertension, acidosis was there, and some microscopic hematuria. And then on top of this, ultrasound showed medullary nephrocalcinosis and some right upper cortical cyst and some right renal calculi. So there was a mixture of findings, and he had actually been started on alkali. But because of this, we decided to do a clinical exome sequencing and was actually surprised to find that actually it had a PKHD1 mutation, which was present to suggest a poly-ARPKD. So something that needs to be just, I thought I'd highlight is that actually many times nephrocalcinosis may be mistaken for actually polycystic kidney, especially the autosomal recessive kind. And therefore, it's very important to use high resolution probes if you have a high index of suspicion for this condition, and actually should be conveyed to the radiologist so that they may actually give you a more accurate diagnosis. So ultrasound is the most important initial imaging test, and when that is performed, and then after this, what is the underlying etiology that needs to be evaluated? What is the underlying condition? And according to, so you go through all the various renal function tests and try to determine what the underlying cause is. And the prognosis of these conditions will depend, of the nephrocalcinosis will depend on what the underlying cause is. For example, primary hyperoxaluria could result in end-stage kidney disease, whereas medullary sponge kidney is a very benign condition, and though it can cause some morbidity like nephrolithiasis, it very rarely progresses to chronic kidney disease. Now, just a point, how do we differentiate nephrocalcinosis from nephrolithiasis when you're doing an ultrasound? And this often creates a confusion in the minds. So there are various ultrasound pictures showed here. This shows a picture of the bladder where you can visualize a small stone. Here in the second ultrasound, this is actually an infectious stone, and there is some amount of calcium deposition. And as you can see, some acoustic shadowing is visible. This is better visualized in the both X-ray. This is a staghorn calculus, and you can see this acoustic shadowing, which is very typical of presence of stones. So there may be presence of both stones and some degree of nephrocalcinosis. And when you look at this picture D, there is some acoustic shadowing as well as some deposition in the medulla. So this condition, actually, you can see a bit of both. But here, this final ultrasound where you can see very dense deposits of calcium in the renal papillae in the medulla, and this is very, very definite nephrocalcinosis. So these will help you distinguish between these two conditions. So subsequent diagnosis, as mentioned, would depend on what you would be suspecting clinically. So you have to do the electrolytes, calcium, phosphate, urine pH. If there's hypercalcemia, you'll have to evaluate for the underlying cause. If there's hypercalciuria, in the absence of hypercalcemia, you would look for different variety of disorders. If there's hyperphosphaturia, in the absence of hyperphosphatemia, then you could be considering possibly hypophosphatemic rickets and some other acquired form due to a tumor, or it may be even a kidney transplant recipient who may have hyperphosphaturia without hyperphosphatemia. And also neonatal primary hypothyroidism, we should consider furosemide-induced nephrocalcinosis, Williams syndrome, or distal RTA. So the etiology of nephrocalcinosis may not be sometimes apparent on history or physical exam or even by your lab testing. And therefore, in these situations, genetic testing for monogenic disorders of nephrocalcinosis should be considered. So now coming to what I would think is probably the most important probably role in today's day, where we adopt a more precision-based approach to the diagnosis of nephrocalcinosis. So though the genetic causes of the nephrocalcinosis and lithiasis are rare, but they do account for a significant disease burden, and many of these may develop end-stage kidney disease. So identifying these genetic mutations in the hereditary cause of nephrocalcinosis may provide valuable insights into these inherited tubulopathies and include both hypercalciuria and various other varied phenotypes of these conditions. So now genetic tests are more freely available. It is not as expensive as it used to be, and therefore a more precise approach is actually recommended. It may also offer some chance for prognostication if we diagnose the conditions early. It may provide opportunities for family screening, and therefore you may be able to screen siblings and other family members, which may also help to treat conditions early, or may also play a role in situations where transplant may be indicated in these patients. And also it may have a very important role in pre-implantation genetic diagnosis. And many patients often inquire about this, whether their next children may be affected, what are the chances that their next progeny would be affected by the same condition. And therefore, knowing the mutation associated, it may actually help with prenatal screening. It also may help to improve the outcome because you may avoid unnecessary medications. Sometimes patients with dense diseases are mistaken for conditions like nephrotic syndrome because there is quite significant tubular proteinuria, and they're not able to distinguish whether it is glomerular or tubular. And therefore, sometimes a genetic diagnosis may actually pin the disease of dense disease, may help you start treatment early, and may actually delay the progression to end-stage kidney disease. And therefore, or the other way around, it might actually help for once end-stage kidney disease occurs, may actually necessitate early renal replacement therapy and more aggressive therapy. And at the same time, conditions like distal RTA, we know that there's a good renal prognosis, and therefore if there's some difficulties in making the diagnosis, it may be actually picked up very well by genetics, and the different types of mutations, the different associated problems, like you have hemolytic anemia, you have hearing difficulties associated, spherocytosis. So the different types of distal RTA also may be better categorized. So it is a key for therapeutic key therapeutic targets may emerge and may actually totally revolutionize management in the future. So the various monogenic causes of nephrocalcinosis have been now identified because of increased use of these genetic and clinical exome sequencing. And we've been able to identify various transporters, channels, and receptors that are involved in the reabsorption of calcium and phosphate. And many of these genes are associated with nephrocalcinosis and nephrolithiasis. And naming just some of the few that I've just named a few, but as you saw, the list was very long and have definitely changed the approach to the management. There are also various of these proteins and variants like phetuin and uromodulin may actually be protective against nephrocalcinosis, and picking up these also may be quite useful in our management. And this is just a study which was fairly recently published in the Kidney International and actually showed the role of genetic testing and how these were pediatric as well as adult patients, and how 14 out of 13 genes were analyzed in 50 of patients. And this molecular diagnosis actually was made in almost 15% of all the children that they analyzed. And therefore, it just highlights how that it may actually help in diagnosis of these conditions. Now, treatment again will depend on the underlying cause, and treatment includes correction of hypercalcemia, and in very severe cases may also there may be require parathyroidectomy in primary hypothyroidism and glucocorticoid therapy in sarcoidosis. So these are some of the specific conditions where specific treatment may be required, but otherwise the aim is to reduce the urinary concentration and increase the solubility of the substances that we have talked about, calcium, phosphate, and oxalate, which are actually increasing nephrocalcinosis. So broadly, it requires giving a very huge fluid intake and to produce a very good urine output, which may be beneficial in patients with nephrocalcinosis as well as nephrolithiasis. Patients with hypercalciuria, urinary calcium excretion may be decreased not only with fluids but also by dietary modification, where we restrict intake of animal protein, restriction of sodium intake, and liberalization of potassium intake. And if these measures do not work, then we help to reduce the hypercalciuria. Then a thiazide diuretic may be required, because if there's no hypercalcemia, it helps to increase the calcium absorption from the gut. Citrate may also be required because it helps to increase the solubility of calcium in the urine and limit the development of nephrocalcinosis. Among patients who have hypocitraturia and urine pH less than 7, we may also give potassium citrate in order to achieve a normal urinary citrate level. And specific management may also be required for other conditions that may cause nephrocalcinosis. Coming finally to the prognosis and to my final slide. So the kidney prognosis of nephrocalcinosis is dependent on the underlying cause. While most diseases with nephrocalcinosis do not progress to kidney disease, certain underlying causes, if not effectively treated, are more likely to be associated with chronic and progressive kidney dysfunction. And these conditions include primary hyperoxaluria, hypomagnesiemic hypocalciuric nephrocalcinosis, and dense disease. These are the ones that are most likely to progress and therefore should be identified early and treated early and treated aggressively. Patients who develop medullary sponge disease or distal RTA may rarely develop chronic kidney disease. So the spectrum is varied. Once nephrocalcinosis is detected radiologically, it is unlikely to be reversed. It is already significant, and therefore serial ultrasounds may not really show any decrease in nephrocalcinosis, how much ever aggressive your treatment is. Some partial reversal has been reported in some patients who have been able to successfully treat hypercalciuria, and some patients who have hypocalciuria following corrective intestinal surgery. So some of these minor causes, like which are brief and which may be due to increased absorption, or some acute causes, we may be able to reverse. And complete resolution of neonatal nephrocalcinosis is generally observed when furosemide is stopped, and therefore in the neonatal period it may have a good prognosis. So with that, I shall end my talk and happy to take questions.
Thank you so much, Dr. Agrawal. This was an excellent talk and such a nice overview of nephrocalcinosis. And it is actually, so nice to see that Dr. Baum talked about the claudins, how they work in the kidney, and then you giving us the clinical implications of the claudin, talking about the hypercalciuria and associated hypomagnesemia with claudin 16 and claudin 19. I think, it is very nice to see the connection between the research side and then definitely the clinical side. So thank you, both Dr. Baum and Dr. Agrawal for sharing your insights, and both, for your wonderful talks. As the questions are coming in, I do see one question in the chat. Meanwhile, as more questions come in, I can actually ask the first question. And if Dr. Michelle Baum is available, I can start with him, or, yep. Thank you, sir. So the first question which I have is regarding, you explained to us such a nice way the difference between the neonatal kidney and how the changes happen in the adult kidney. The question which I want to learn is, what is the difference between the extremely premature neonatal kidneys? Because as we see clinically more 24-weekers, as we see more 26-weekers taking care of them, and when we compare with them with a full-term neonatal kidney, what key differences would you like to highlight?
So they're very likely to have salt wasting, fire supplementation. They'll also have glucoseuria. And if measured, which we don't, amino aciduria would be more profound in the very, very premature neonates. And again, I think that when they are older, I think that they're going to be predisposed to having chronic kidney disease and hypertension and proteinuria.
Yep. No, thank you so much. And on the same line, Dr. Agrawal, I would like to ask you that, again, as we are dealing with more premature neonates, we are using more diuretics, more Lasix, we are predisposing them to nephrocalcinosis. Now, in your experience, when these patients do develop nephrocalcinosis, how long does it take to get resolved, after stopping the diuretics? What would be the timeline that you would like to say?
So the cases that I have seen, we tend to repeat the ultrasound in about 6 months' time. And as mentioned in the case that I went through, we were able to see that there was complete clearance. So I presume, we haven't studied them to really look at serial ultrasounds, but I presume if it is due to that, then probably 6 months. But yeah, I don't
That's
know.
great. And I really like the point that you made in your slide that we don't know, how frequently do ultrasounds on these, and do they actually resolve or not completely? And I struggle a lot when, when we're taking care of kids with Bartter syndrome who develop nephrocalcinosis, sometimes, distal RTA kids who develop nephrocalcinosis, how frequently to do ultrasounds on them? Does it really help? Does it not help? Any thoughts on that?
Oh, I mean, we do try to do ultrasounds in our children, say once in 2 to 3 years. Also because, you want to monitor their growth and you want to see that the kidneys are growing. And so, but I don't think I've come across even one ultrasound where I have seen a reduction in the nephrocalcinosis, and especially in Barters and distal RTA, which really form the bulk of our the children we see. And most of them, it is as dense as it was on day one, in spite of the general condition improving, in spite of the hypercalciuria. Actually, we are able to control the hypercalciuria with our medications and with the, excessive fluid intake, and most of them, the electrolyte abnormalities resolve. But I have yet to see a nephrocalcinosis, which has actually decreased also with time. So that's with my experience.
Dr. Baum, we would love to hear your opinion also on, how frequently you would do ultrasounds on nephrocalcinosis, and do you see them resolving, especially in distal RTA and the Bartter syndrome kids?
So in Bartter syndrome, all of the types of Bartter syndrome will have nephrocalcinosis, except for due to the chloride channel defect, where some of them do not have nephrocalcinosis. If they have it, it does not resolve. And in the neonates, I leave it to Dr. Agarwal. I'm not as expert as she is.
Thank you. We do have a couple of questions in the chat box also, so I will go through them. So the first question is, are diuretic plants cause of nephrocalcinosis?
Can you repeat that? Diuretic?
Plants.
Plants.
Yep.
But when do we use the in our clinical practice? So I'm not sure. I mean, maybe they can clarify a little better what they really asking about. Which plants are they talking about?
Right. And I would think the same. I think, plants probably, these are the regular herbs and regular plants that we use probably in day-to-day food, which may have some diuretic effect. I'm guessing, like things like garlic and all that we used to read that may be some diuretic effect, but I have not heard that would cause nephrocalcinosis. But that's an interesting question. Next question I have is, it says post-transplant nephrocalcinosis from Dr. Sundarajan. So I think he wants to know more about post-transplant nephrocalcinosis. So if you could speak of that a little bit.
I would just say that I really myself don't really have enough experience with that. And I haven't actually, don't have any information on that. I haven't actually gone through that. We are a very budding center when it comes to transplant. So we have seen hypoparathyroidism in our children. We have seen some of them developing nephrolithiasis. But I can't really say I have experience in this. So I don't know if you may have any experience because you're a much higher volume center, whether you can share any experience on that.
Yeah, no, even our experience with nephrocalcinosis post-transplant is not as much. We don't see that very commonly. And again, we avoid use of diuretics, especially Lasix in these patients. And even I have not seen as much. So it's not a common entity that we deal with. I think I have one more question in the chat box, and it says, does parathyroidectomy resolve the nephrocalcinosis in primary hyperparathyroidism? Again,
this is something that we don't really see too much of. And I mean, I don't have any experience of this. I mean, we rarely do parathyroidectomy in children. And even if in, severe forms of CKD, where you may have a tertiary hypoparathyroidism. So again, I don't have any experience on this. Possibly the endocrine people might be dealing with the very severe forms of hypoparathyroidism, and they may have specific indications.
Right. And then, as you said, I mean, even I think in children, we rarely do parathyroidectomies. It's a rare indication, especially when you're dealing with renal failures and all. And most of the time, by that time, the nephrocalcinosis is probably severe enough. And again, how long do we follow them to document that resolution has happened? I feel it's pretty challenging. Once you develop nephrocalcinosis, except when it's diuretic use or Lasix use, other conditions, it's very difficult to demonstrate resolution, and it seems to continue to stay for a very long period of time.
The only thing is, I think in itself, it doesn't really damage the kidney. It's probably the other causes which may contribute to worsening renal function, and for which there may be multiple causes. Besides the underlying disease, many of these children have polyuria, polydipsia. They may be chronically dehydrated, chronic hypovolemia, which results in some degree of loss of function. But I think per se, the nephrocalcinosis really doesn't cause too many problems in itself.
Yep, sure. Dr. Baum, I have one question, and this is more related to the phosphate handling in the kidneys. And these days we talk about, FGF23, and then we have the FGF23 inhibitor now that we use in hypophosphatemic rickets. Would you like to comment on what is the difference in phosphate handling, or I should say more like FGF23, levels when we compare the adults versus the neonatal kidney?
I'm not sure what the levels of FGF23 are in the neonate. I know it's been done. I just don't recall it. However, interestingly, the serum phosphate levels are higher in neonates than they are in adults, and there is evidence for an isoform of the sodium phosphate cotransporter that is more active in the neonate than it is in the adult.
Yeah. I think that's very interesting, how FGF23 levels can still be similar in neonates and adults, but then the phosphate numbers can, as you mentioned, that they are higher in neonates. And it's an interesting comment. So I think I have one more question which has just come up in the chat box. It is, can acute kidney injury in neonatal period cause nephrocalcinosis that does not resolve, but with normal tests of kidney tubular function?
That's a little complicated question. So why would acute kidney injury cause per se? So unless it's drug-induced, again, it comes back to use of Lasix and furosemide and drugs, which would cause nephrotoxicity, which would cause renal failure, which could cause nephrocalcinosis. So it just depends what is the precipitating factor that is resulting in this problem in Africa. It's not a very common thing that we see, except in that group of neonates who have, used furosemide. Any other causes, I'm not also aware of that I've actually seen in my personal experience.
Yeah, thank you. I think we are past 10:30, US time, and here I think that's all the questions we have in the chat box. Does any panelist have any questions? No. Okay. So thank you, Dr. Baum, again, for joining us. Thank you for a wonderful lecture. Thank you, Dr. Agrawal, for joining us and, for sharing all your clinical experience. We do have a polling session right after this, but, you can carry forward with the rest of your day. But if you would like to continue with the polling session, you are welcome to stay back. So thank you again for, joining and sharing your experiences.
Let me see what this polling session is about. I've not seen it before.
I'll hand over to Dr. Kalavani for the polling session.
We'll go up with the instructions of the polling session now. So all participants are required to enter a proper email ID and contact number. So we are already done with 3 polls. We are left with 2 more polls, excluding today's event. And each polling session has got 10 questions, and it's mandatory to answer all the questions to proceed with the submission. And in case of tie, we have 3 star questions, and we should know that all the cumulative scores are taken for the awardee. I think we'll go ahead with the polling session now. So the total time is going to be only 8 minutes. It's not 10 minutes. Time starts now. 2 more minutes left. We've got 30 more seconds. We'll stop the polls now. Thank you so much, Indra ma'am.
I told her, if you give 10 minutes, they'll all Google the answers. And
That's true. That's why I had reduced it to 8 minutes today. Probably from next session, we'll have to make it 5 to 6 minutes.
they say whether how much they retained, and some things you may not know. But 10 minutes, quickly look it up.
That's true. That's true.
They will still read it, so you know, they will still learn something out of it.
It's just a learning experience. It's more for pediatric trainees as well. So it is going to take some time for them to actually recollect and answer.
Oh, it's good. No, but you didn't think of that.
No, I thought, ma'am, that's the reason I made it 8 minutes today, because we had very short questions today. Rest of the days we had little lengthier questions. Thank you so much, Indra ma'am. It was an extensive session. Thank you so much.
Yep.
I wanted to ask Amrish, you must be knowing Rachita also. I forgot about her. Rachita?
Yes. Mm-hmm.
Trained with
Yeah,
you?
Rachita Dal. Yeah.
Yes.
Yeah, she trained at our place, and she's at CMC now, or?
Was here with us for a year. When she
Okay.
was married, she went back to Delhi. Now she's at Lady Harding's.
Right, I thought so too. Yeah, no, I mean, Rachita I know very well, so.
Very nice person. We
Yes.
learned a lot from her as well. Very nice person as such.
Yeah,
Okay.
no, thank you so much, ma'am. You know.
Good to.
Thank you, Dr. Amrish, for the excellent moderation.
Yes, yeah, you did well. Good.
Yeah.
Okay.
No, thank you.
Good night.
Okay, good.
Thank you, ma'am. Good night, ma'am.
Thank you. Bye-bye.
We
Bye.
won't meet Tipna, but somewhere else maybe. Yeah.
Right, we should definitely meet, so.
Okay.
Bye-bye.
Good night.
Bye, ma'am. Good night, ma'am. Bye,
Yeah.
Amrish.
Thank you, everybody. Thank you, all the attendees. We are closing.